Staging for lung cancer is a process that goes through multiple steps. One of the first things that we do is a history and physical exam, because some of the aspects of staging can be detected just by good history taking and discussing with the patient. But I think what people most recognize is things like a CAT scan, a CT scan, that gives us really important information about how big the cancer is, whether it sits next to anything important, whether there's any enlarged lymph nodes nearby, or even whether there might be evidence of spread to other parts of the body that is visible on that CT scan. Then almost routinely we do a PET scan called a PET scan for positron emission tomography, a completely different type of scan that looks at the sugar molecules in our body and how they're taken up in cells in our body, because cancer cells are much more aggressive users of sugar than our normal cells. And so cancer cells will tend to light up or be hot on a PET scan and give us a great chance to see from a PET scan, are there any other areas that are lighting up or hot on a PET scan that we didn't detect before, but would be important to know about, and that might represent a more advanced stage or something that needs to be evaluated or biopsied. And finally, all of that is what we call non-invasive staging, things that don't enter the patient. But then we have invasive staging, which has to do with biopsies, and biopsying a spot in the liver or in another part of the body that might be a spread or metastasis of cancer. And very frequently biopsy of lymph nodes in the middle part of the chest where lung cancer tends to go to. And those can be biopsied either with a needle through a procedure called a bronchoscopy with endobronchial ultrasound, or with a minor surgical procedure called mediastinoscopy. Both of those very effective ways of looking at lymph nodes in the middle part of the chest to make sure that those lymph nodes do not show any sign of cancer spread. It's important to recognize that as important as staging is and as sophisticated as our tests have become, they are still not infallible. Staging can appear to be wrong, can be wrong. It can be wrong either because a CT scan or PET scan appears to show spread of disease that's actually something else and is not a spread of cancer, or because a tumor is sitting next to another part of the body that is interpreted by the radiologist as maybe invading and being more aggressive, yet it is not, and it takes actually an exploration and an evaluation to know that. So it's important to recognize that staging is critical. It's really important for making the right choices in treatment, but it's also not infallible. And we go through many steps to try to be sure that if there's expectation or any identification of more advanced disease, we try to prove that it really is more advanced before we assume that. A philosophy that I've had in caring for lung cancer patients, and that I think our whole team has, is when there's any doubt, that we want to give the benefit of the doubt to the patient and not to the cancer, and give them their best chance for curative intent therapy.